I won't stay longer. मुझे फिर जाना पड़ेगा.
Yes.
Okay. Sangeeta, you want to check your presentation or it's okay?
Yeah, if you say I can do that, share screen करके.
Yeah. I check. I think better to check. Yeah.
Because.
Can you see?
Yeah.
Yes.
Absolutely right.
Yes.
Perfect. That's all right.
Okay, fine. Then I'll skip now.
And Datta, what about you?
Yeah. I will share my in 1 minute.
I think yeah, got it.
Oh, can you see? Can you see my presentation?
Yeah, we can see.
You can see, no? Okay.
Yes.
I will exit.
Yeah, exit. And now.
1 minute. How to exit? How to exit? 1 minute. I will. Okay.
Okay, Nilesh is there. Nilesh, hi.
Good evening, sir. Good evening.
Very good evening.
Hello.
This meeting is being recorded.
Hello, Nilesh.
Good evening, sir.
Helen, good evening.
Hi, Nilesh.
Hello, madam. Hello. Good evening.
Hi, good evening. Yeah.
Now, Shwetal, I think. Shwetal, do you want to check your...
Yeah, I think I'll do it. I'm sharing my screen. I hope it is seen.
Yeah, it is seen. Yeah, it is still open.
It is a blank
slide.
Blank slide to begin with. Yes, of course. Well, all right. I'll stop sharing for now.
Suddenly some news. Okay.
Somebody is singing.
This is being recorded, no?
Recording started already? Sarang?
Yes, recording started.
Started already. Why we started 8 o'clock? We're just checking. Somebody singing, correct. Sarang, can you in the meantime put up the program actually if you have the brochure or flyer with you? Okay. Datta.
बोलो.
Call up Dr. Depujari and see if he's.
I spoke to him just 15-20 minutes ago. So in fact, he said that he will be there throughout the program because he had to go somewhere in between. But he said I'm there all the time.
I know.
I said that's good. So he should join. Phone करूँ क्या?
I don't know. Let's wait. He knows about it anyway, so let's just wait and see.
Two minutes to start.
So, I will start, Datta. Then I think Dr. Depujari should take over and then he should moderate the whole thing with you guys. Okay.
Is there a Q&A session as well at the end of it, Suresh?
What session, sorry?
Question answer session as well? Are
Yeah,
there...
of course, yes. It is more of a discussion thing, so if you finish, 15 minutes each, we will be left with another 30 minutes to discuss the things.
So who's going to do the question?
Dr. Dev Pujari.
Just a general discussion. It's not something.
General discussion. And then Nilesh and Amit and you should continue the discussion. And
there will be some questions in the chat box.
Chat box also. Yes, you're right. There'll be some in the chat box also.
So these questions in the chat box will be put by the
audience.
And where is the audience visible to us? Means I don't mean visible, but do you know of their participation?
If somebody wants to be visible, we can make him visible, because there is a scope to have multiple, pictures on the screen.
No, I don't mean it that way, because I can see only 12 participants just now.
I know. Most of them, do not want to come front. They just keep asking the questions from the chat box, and that's it. But if somebody wants to come, we can put him on the panel. No, not a problem.
But how do we know how many participants are there? That is
it is written down then.
At the bottom.
No, at the moment there are 13, right?
Correct.
So that's what I think Milind was asking, whether we
Sarang, we can call someone, can we?
Yes, we can always unmute anybody who raise the hand or raise the question in the chat box.
Okay, but then these 13 people who are connected just now, we don't see their faces.
No, because they are mute, and I think their videos they have stopped.
Okay, they have stopped the video.
Okay.
All right.
I think it is 8 o'clock already, Suresh. We should. Dr. Dev Pujari is not still come.
I don't see him actually.
I hope he has the link on the email.
Should I ask him quickly and see what is happening?
I'm calling you.
Okay.
He's joining.
Okay, so as soon as you join,
we'll
start.
Hi everyone.
Hello, Kishore.
Hey Datta, how are you?
Hi. I'm fine. How about you? Everything fine?
Yes. Great. Yes.
Okay. Good.
This post attendee Zoom is seen whose? Is someone's screen?
This is Suresh's screen.
Acha, okay. I was wondering what's happening.
Yeah, so I can.
ऊपर लिखा है देखो.
Okay.
I just forgot to unshare this thing. Sorry about it.
Yeah, Dr. Dev Pujari is joined already, I think.
There he is.
Yeah, sir is there.
Hello.
Good evening.
Good evening, sir.
Hello, sir.
Can we start the webinar, Dr. Dev Pujari?
Yeah.
All right, Sarang.
Yes, sir. We can start.
Recording started?
Yes, sir.
Okay, then. Good evening, friends. On behalf of the webinar committee, I would like to invite you all to this fascinating webinar today. this is going to be the seventh of the series of webinars that MCNS has done so far. The previous 6 have been selected very, very cautiously on interesting topics which we come across every day-to-day practice. This one today is very special, not only because the topic itself is special, but also that this time we have managed to get the outstanding speakers and the panelists for this webinar particularly. So without wasting much of time, I would invite Dr. Dev Pujari. Dr. Dev Pujari is going to moderate this entire webinar today. Everybody knows Dr. Dev Pujari, so I don't have to waste time on any introduction of Dr. Dev Pujari. Every speaker has got 15 minutes time to finish the presentation, and then the remaining 30 to 35 minutes, we will have question answer sessions and from the audience as well as the panel discussions. And we have chosen a good experienced panel for this discussion, which includes Dr. Milind Sankhe. He is from Hinduja Hospital, Dr. Amit Takoji, and Dr. Nilesh Kurvele. So with all these things, I hand over the mic to Dr. Dev Pujari to moderate this session. Thank you. Thank you very much and welcome again to this webinar.
Thanks, Suresh. Thanks, MCNS, for this opportunity to be part of this webinar. And I am sure that we will have an interesting session for the next hour and a half. I think the webinar committee has decided on a good idea that we should probably concentrate on a topic. So we have been fortunate enough to get Dr. Sangeeta Rawat, who's not only the professor of neurology at the KEM hospital, but she's also now the dean of the hospital, and thankful for her to join us today. And she's going to talk about the most important aspect of epilepsy surgery as to how to choose the correct patient. Because I think apart from the surgical technique, etc., which is going to be discussed in detail, choosing a patient forms an important part of epilepsy surgery. And there it is indispensable to have a good interested neurologist when we are embarking upon this field. That will be followed by the talk on medial temporal epilepsy by Dr. Muzumdar, who has now a vast experience. And we are also going to learn something about the nuclear medicine, how it has contributed to identifying and evaluating patients. So I would request to open the session with Dr. Rawat, who's going to talk about pre-surgical evaluation.
Yeah. Thank you and good evening to all. And thanks to Dr. Dev Pujari and Dr. Sankla and all for giving me this opportunity. I remember when I started this, I used to talk about this topic very often. But now after a long time, I'm going to share this topic again. So today's my topic is, you can see my screen?
Yeah.
Yes.
You can
yeah, I'll do the full screen. Yeah. So today it is on pre-surgical evaluation. And as Dr. Dev Pujari said, I also agree that neurologist plays a very important role in selecting the correct patient and selecting the correct area to be resected. This is where the epileptogenic focus is. So we all know that epilepsy affects almost 1 in 100 was previously said, but now they say 5 in 1,000. And we have a great prognostic. There are 30-40% of patients who have a genetic epilepsy and go into remission. We are the lucky ones. And others 20-30. Anything? Can you hear me?
There's a lot of echo in the background, Sangeet.
There is either another device in your room.
Yeah, just
some mobile or something.
Okay. Yeah, I will stop the mobile. Just a second, mobile also has to wait. Yeah,
as we can see that your ma'am, excuse me, as we can see that your internet is not stable actually.
So
Fine. It's fine now. You can continue.
Yeah. That's right. It is connected to my mobile also. That's why there is a right. So, is that okay now, Bhagesh?
Slightly better. Yeah.
So, the second is which I want to addition to 30% of, and the rest 20% remain in the consistent seizures, and which constitute the epilepsy. As the definition of refractory epilepsy goes, failure of adequate charge to tolerated and appropriately chosen, which means that for a myoclonic seizure, you are not chosen a carbamazepine, but you have chosen valproate. And AED schedules either in monotherapy or in combination, and they fail to achieve a sustained seizure. Seizure-free for a minimum of 3 times the longest pre-treatment inter-seizure interval or 12 months, which is very longer. So if it doesn't control, then it enters into a vaccination of drug-resistant epilepsy. So now let's go to the comprehensive epilepsy. It's a team approach in a systematic manner, which will benefit these type of patients who are re-evaluated in these centers, and the pre-surgical evaluation is done, and the team members are all which are listed. So when the patient referred to us, they go into a detailed evaluation, which includes history, examination, EEG, and imaging, and often the diagnosis changes after that, and they may get controlled. But if they don't get control before they go into evaluation of EEG, whether they are non-epileptic events, whether they are psychiatric or epilepsy, or they have to monitor surgical management, that is to be decided by the team. It is important that the pseudo-refractoriness has to be identified only the amount of diagnosis, maybe the syncope or EEG, and it is labeled as seizures, and they are not being coming into control when it comes to seizure medications. Either there are errors in the drug choice, which I said, like carbamazepine or others which may exacerbate the myoclonic jerks. And there is a poor medication compliance by the patient, so the patient has been given, but they don't take medications, and there are either intolerable side effects or the patient has decides not to take it. So once we know all this pseudo-refractoriness, which are the surgically remediable epilepsy syndromes? The most common one is the mesenteric epilepsy with changes of hypertrophic sclerosis, benign neoplasms like angioedema, astrocytoma, oligohydroplasma, developmental lesions of the spasms, and other vascular lesions like scars or vascular malformations, encephalitis, etc.
Madam, I'd like to halt you just for a second, ma'am. Your audio is not at all clear. So is there any other device parallelly running in the room where the Zoom is been working?
Apart from this laptop.
Because what I can see is your internet is fine right now, but there are some background music which is going on. So what I believe that your internet is sorry, you might some other devices active in your room.
It's not you alone. There has to be. Have you opened up Zoom on your phone or your tablet or somewhere else?
Ma'am, can you do one thing? Can you switch off your video and then talk, ma'am? Let us see if there is some internet issue. So that will take a very less bandwidth to start your session. If you can switch off your video and then talk. Please speak, ma'am.
Can you hear me now?
Audio is still not clear. So
should I try my screen internet with the water internet which I was trying? Should I try?
You can log off and again log in, join again.
Another option that you can just leave the meeting and rejoin it, ma'am.
Yeah.
I'm trying to jump on my internet.
Hello, sir, Dr. Dev Pujari.
Yeah.
Sir, a request. Maybe after Dr. Rawat's talk, maybe Shwetal can talk and then I can talk. That would be better, I think.
Yes, I think that's a better way. Yeah.
Okay.
Agree.
Yeah.
Yeah, is it better now? Hello?
No, it's equally bad.
I will change the internet bridge.
Can you do something else? Can you probably speak from your phone? Keep the audio off on your laptop.
I will change the internet bridge and they will get better and sort of like that. Yes. Okay, can you hear me better now?
Can you talk, madam?
Can you hear me now?
A little bit, but not very clear, but little bit.
Yeah. So I don't check the better things. I think you can see my slide. So I can go that over. Hello?
Ma'am, are you sure that you have not logged in by any other device?
No, this other
Actually, audio is not clear, ma'am.
So I actually now taken my mobile internet also. So that hotel internet are not happening.
There is a clear echo. There are two voices.
Can I
Two voices coming, ma'am.
There are two voices coming. There is something else on.
Hello?
Yes, ma'am.
Are you with earbuds as well as audio? The laptop is on. Does that happen? Can you get a duplicate voice that way? You have earphones. Bluetooth earphones. If you have Bluetooth earphones, you can probably silence your laptop.
Ma'am, don't use earphones, ma'am. Talk directly with the system. You can start, ma'am. Let us check your voice now. Ma'am, you can give a try, ma'am. Ma'am, can we give a try?
Are you online, Dr. Sangeeta? Have you disabled your Bluetooth?
We are seeing the screen, but we are not hearing her.
Is your Bluetooth on?
Hello?
Yes, madam. Can you talk, madam?
Please talk, Sangeeta.
Hello?
Yes, we can hear you.
Yeah, is it better?
No, it is the same problem.
Ma'am, are you using any headphones or a Bluetooth device?
Yeah, I was using that. I should stop
Can
that?
you disable that? Can you
Right
disable
now, are you
that?
talking directly with the help of your laptop?
No, I'm still with it. I could not disable it. I will disable it now. Okay.
It would be great if you can disable the Bluetooth actually.
So how do I do?
Okay, so I'll help you out in that with the device what you're wearing in your ears. You can disable that.
You use computer audio when you are in your system.
Okay.
Or then you say don't use computer audio, and then you can use the Bluetooth.
Okay, fine, I'll do that. Okay, I'll just rejoin and I'll just rejoin and do that. Okay?
Yes, ma'am. You can rejoin the meeting, and when it again asks you join with computer audio, click that.
Yes. Okay, fine.
Team, can we have everybody's pictures on? I'll click a screenshot actually for our website. Oh, that's lovely. Can rest of all click their videos on? I'll just take a screenshot and you can go back with the.
No, your voice is also going, man.
Am I audible now?
Yes.
Yes.
So let's take a picture. Fair enough.
But our madam is missing. So you'll have to take one more.
Yeah, I'll take again.
And Nilesh is missing, I think.
No, Nilesh is there.
I'm here.
Okay. Okay.
He's there, sir.
Everybody's there.
There is other alternative. Can we start Dr. Shwetal's talk first? Saves a little time.
Yeah, I think that would be a good idea.
All right. I'm okay with it.
Huh.
Shall we?
Let's ask.
Are you
Sangeeta.
ready with your talk?
Yes. I have already tried. I can right away share the screen.
You are ready to share your screen. I think we can take that talk first.
I hope I'm audible well. There is no issue.
Sangeeta, it is okay if we start with her. Sangeeta?
No, you will have to talk to her on her phone. She is not joined yet.
I can see her picture though. Photos coming.
Can see her picture. I am missing it. I don't know. No, I can't see her.
No?
I don't think she is online yet.
Hello? Hello, yeah, I told her she is going to take time. So let us start with
Let Shwetal talk first. Yeah.
All right, fine. I hope I'm audible well. So I think I'll
Yes,
share my
ma'am,
screen.
loud and clear.
You are audible, visible. Your slides need to come on.
Yes. All right. So to begin with even if it is a blank slide, we'll start. Well, a very good afternoon, good evening, I'm sorry. And I must thank the Dr. Mujumdar and Dr. Dev Pujari and also Dr. Sankla and your entire team, and also Sarang Rote, he being my MBBS batchmate just to, so we already have a connect with your team. To begin with, the neurosurgery, team with the pre-operative evaluation, I understand that obviously the neurosurgeon's perspective and a neurologist's perspective is the first one to come. We are the last one in the entire workup, but still, anyways, for the time, we'll start with what I have to offer. Well, in this talk, we will be discussing mainly about there are various radiopharmaceutical, which are the tracers that we can use, but I will be only concentrating on two tracers. So one is for the perfusion and one is for the metabolism. So we will be talking about the ECD brain SPECT and the FDG brain PET. So which is extensively used, which is available to our pursuit right away, and we are using it and how it is helping the decision making. So in the entire spectrum of drug resistance epilepsy, well, obviously the first line of investigation is obviously the clinical acumen, the clinical suspicion, along with the structural imaging of MRI, the electroencephalogram, which is the EEG, wherein the first workup is done. And the next second line investigation is always the nuclear medicine investigations when you are in doubt. Obviously, with respect to either a normal MRI or discordant findings based on MRI and EEG, there are multifocal MRI findings and there is discrepancy between the two earlier investigations. So obviously, working towards the preoperative evaluation, we need to have two investigations which are concordantly suggesting the focus of epilepsy, which would be which is the way the patients are worked up. So this is the indication where you have discrepancy, multifocal, or in doubt with earlier two investigations. The next step is obviously would step in is the nuclear medicine investigation. So we have various other tracers to offer, but we will be talking extensively, as I said earlier, about the ictal SPECT and the interictal FDG PET. So here we are to begin with the ictal and interictal specs. So I will be telling very basics how it is being worked up and what is the indication where we are using and how it has helped us in a few cases. So what we are mapping here is the brain perfusion. So the radiopharmaceutical that we are using is ECD. It gets locked at the baseline perfusion level at the time when we are injecting, and once it enters into the neuronal cells, the gray matter, it is locked inside the intracellularly, so it does not redistribute. So what we see is the actual brain perfusion at the time of injection. So we can perform it two ways. One is ictal, which is epilepsy. I'm sorry. And during the interictal phase, which is interim between the time of two epileptic foci. So just in briefly how this procedure is being done for those who are not performing it very regularly. So the patient is put under the video EEG recording for almost 2 to 3 days, where the anti-epileptic drugs are tapered. And obviously the type of epilepsy which is being evaluated, the patient is injected the radiopharmaceutical, which is the isotope, right during the epileptic focus. So which is recorded based on the video EEG, and at the same time all video EEG technicians are trained for this in all the setups where this test is being done. And so the radiopharmaceutical or ECD tracer would get localized in the brain parenchyma, the gray matter, at the direct proportion to the blood flow. So it is actually depicting the perfusion at the ictal focus level, at the ictal phase. And then the imaging is done subsequently after half an hour when the patient is stabilized, and we are actually mapping out the brain perfusion during the ictal phase. Now this same procedure is repeated at interictal because we want to find out the baseline perfusion in the brain parenchyma, in the brain cerebral region, so as it is compared at the ictal and interictal to locate the focus of epilepsy. Now here this is a technically demanding procedure wherein you have to have a right selection of epileptic focus. The duration of epileptic focus needs to be longer enough that you have time to inject the tracer. The video EEG technician has to be very, very prompt to select that epilepsy and inject at the right time. And the imaging along with further interpretation has to be also coordinated and reported always in congruence with the video EEG finding and the MRI finding. So no nuclear medicine findings are rather decision making in epilepsy surgeries are always done with the team with consideration of other investigations. So this is one of the cases where, which is the most common indication where we are doing the ictal spect is when you have discrepancy between the video EEG finding, which is showing one-sided epileptic focus, where in this case it was left temporal epileptic discharges during ictal phase, MRI showing the bilateral MTS, and obviously the question was which exactly, because we need to have two investigations going congruent for consideration of epilepsy surgery. So here, as we are seeing by the arrow marked, that the left temporal region was showing increased perfusion in the ictal phase. The upper limit is upper line is the ictal phase. The lower is interictal, which would show reduced perfusion in that region. And this lower line is the subtraction image, which is the software subtraction imaging between the interictal and ictal phase, which will actually give us a epileptic focus. Another case where it is a case of a dysplasia which was localized in the right parietal and parietotemporal region, whereas clinically the patient had CPS with generalization frequently happening with other parietal surrounding discharges and secondary spreads. So again the ictal SPECT study was considered, wherein we are seeing that there is increase, rather normalization of perfusion here. So this ictal focus is confirmed after interictal study, where we are seeing that there is no perfusion in that dysplastic zone, which is showing, confirming that the focus is localized to that region. And particularly in this study, there was no secondary spread, but it has to be correlated very well with the concurrent EEG findings also. Well, are we really able to see the ictal focus every time? No. Yes, there are, since as I said earlier, that it is a technically demanding procedure, quite often the technician has to be very quick in injecting before there is secondary spread, like in this case where there was a hemispheric spread before the tracer actually reached the brain. And here the focus could not be localized in spite of having. So not all procedures are successful. So you have to be very, very meticulous with respect to doing the procedure. The training has to be done, and I think it comes with the practice. So the procedure has to be done very meticulously and reported also in accordance with the EEG findings very clearly to find out the spread. Now, we could do this along with, just to highlight the images, the left side panel is the ictal SPECT, the middle panel is the software MR and PET fusion images. Now, these is done during the interictal phase where the PET is studies compared with the SPECT. So, if you have PET at your availability, the images, the contrast, the resolution of PET images is so superb. And if you can fuse it with the MRI, even the confidence of reporting and even the visualization of the exact hypometabolic or reduced metabolism region is so well done. So currently quite a few studies are done with ictal SPECT along with interictal PET. So in this particular study, there was a ictal focus seen in the right temporal region where there was hypometabolism or reduced metabolism seen during the interictal PET study. So here is some experience that we have been sharing, which has been published in a British journal from our side, where there was a discordant finding on electroencephalogram and MRI findings, and did ECD brain SPECT, ictal SPECT help in this particular scenario. So we have seen that it has shown incremental value in about 75% patients, and most of them, the major percentage where it was most useful is the cases where there was bilateral mesial temporal sclerosis, which is the most common indication, and it helps the best, which wherein the resection of the epileptogenic focus did show a very good post-operative seizure freedom also. So the entire study concluded that there was some incremental value with this discordant findings also. Now coming to the interictal brain PET. Now why interictal? Well, can we go ahead with the ictal PET because of the superb resolution, and what we are mapping here is the glucose metabolism of the brain. Since our brain is the highest glucose utilizing organ in our body, the FDG PET is obviously seen distributed very, very well in the brain, and we are actually studying the glucose metabolism in the interictal phase. Now, since FDG or glucose redistributes in the brain parenchyma till the equilibrium status is attained, the routine FDG PET is an interictal study. So unless, now I will be giving an example where we can also find an ictal focus in the FDG PET, but routinely after the seizure there is normalization of the brain perfusion and the metabolism. So there is always a gray zone of a question where there is, in the post-ictal phase, you may still see epileptic focus, or we may not actually be able to mapping out the actual hypometabolic or reduced metabolism zone in this region. So there was a study which was published in Epilepsy, which suggested, based on the other studies, and also that about the optimum time of doing interictal PET is after 24 to 48 hours of seizure. So which is an optimum time. So every time the patient comes to us for interictal PET study, we always ask them what was the last episode. We also tell them that if the patient is getting any convulsion during the waiting period or during the scan, they're supposed to inform us. And we have seen that it definitely changes the interpretation of FDG PET study. Even if we are doing interictal, we have still localized a lot of ictal foci during this study also. So what we are actually mapping out, the word that is used is functional deficit zone. Now this functional deficit zone is the metabolism, which is the functional representation using FDG brain PET, and most often it is seen more than the structural abnormality seen on MRI, because the surrounding neuronal tissue is also responding to the epileptogenic zone, which also may show reduced metabolism. That is why the word used is functional deficit zone for this particular region. So as I said earlier also, is ictal PET possible? Yes, it is possible if the patient is having continuous running interictal discharges or even repeated or high frequency of seizures. We have actually seen, like in this patient with a large area of dysplasia, there was a focus of epilepsy seen during the interictal PET study also. And when we correlated it well with the EEG findings and even the patient's clinical semiology, the patient did have multiple runs of interictal phase, where interictal phase also did show epileptic discharges. So this has to be very well correlated with the EEG findings. If you find such foci which are suspicious for increased metabolism even during the interictal phase. Now, just visiting a few cases where FDG PET-CT has been useful in predicting, because as I said earlier, we are mapping out the functional deficit zone. So are we really going to subject our entire zone to the resection? Obviously, the answer is no. It has to be correlated with the intraoperative EEG, with the EEG findings, and also with the MR related findings, wherein visit pertinent to consider this zone for resection. And if not, even the prognostication or post-operative prognostication or seizure freedom is always conveyed to the patient based on PET findings. So where it is very, very useful. Now in this particular patient, this patient had a right temporal discharges. Interictal did also, the EEG did also show additional temporo-occipital discharges, for which the patient was sent for the PET, because MRI did not show significant abnormalities in the occipital region other than a few white matter gliotic changes. So here the FDG PET-CT is showing that there is, in addition to the temporal region, the temporo-occipital region is also showing significant hypometabolism, and the patient was suggested or was counseled for for a poor prognosis even in this region, based on the PET and the EEG findings, which were going congruent or which were suggesting the similar findings. So this would definitely help us in the prognostication, the post-operative seizure freedom for these for various patients like this. Now this is another patient where, interestingly, there was a dysplasia seen in the midline in the parasagittal region, and the EEG was showing possibly an artifactual discharges, or if there were bilateral frontal discharges. So FDG PET-CT was advised to rule out any hypometabolism even on the other side, whereas the FDG PET-CT did not show any abnormality on the contralateral side, but the dysplasia region was showing significant hypometabolism, and this region was only resected out, and the EEG findings were considered to be artifactual because of the midline positioning, and obviously the other contralateral side showing artifactual EEG findings. So I think there is always in addition information which would supplement or support the prognostication and even decision making in this particular type of questions. Now, we have done FDG PET-CT where we have actually been given prognostication with respect to larger HI patients where there is diffuse multifocal hypometabolisms and also hemiatrophy or hemispheric involvement in these patients, versus if there are patients with double lesions or dual pathologies, like there is dysplasia in the posterior parietal as well as in the temporal region, wherein the FDG PET-CT was significantly congruent and it did not show significant larger area of hypometabolism. Well, the resection area was decided definitely based on the EEG findings and the clinical semiology as to which was the one lesion which was showing significant epileptic discharges. And so the operability versus non-operability or the prognostication based on the operability is the one that is being guided using FDG PET-CT. Now, now that we're talking about a lot about prognostic information, so how does it help with respect to the lobar distribution? So obviously, if the bilateral temporal glucose hypometabolism is seen, obviously, in addition to the memory performances, we would also give a less post-operative seizure freedom. In the prefrontal, obviously, executive functions. In insular, there would be emotional and somesthetic symptoms which could be prognosticated as poor. In bilateral, lateral temporal, and prefrontal hypometabolism, obviously, behavior-related issues. And thalamic contralateral hypometabolism or epileptic foci has obviously, in literature, has shown poor surgical outcome. So there are prognostic information that is being given by this PET studies. So just to summarize in a crisp way, in a crisp manner, to find out about the ictal SPECT, where will you do it and how it is going to add to the information is obviously, it is indicated when you have discordance between the structural and EEG finding. You would also want another investigations which would support your diagnosis and will help you for decision making. Obviously, if you are finding secondary epileptic foci more than, or if you're finding multiple type of epilepsy, well, you would want to study them more in detail. And in structural imaging, where it is normal, where you would like to decide about intraoperative EEG or invasive EEG before considering the surgical option, this is an additional investigations where you will do it. Now, defining the functional deficit zone using FDG PET-CT, obviously multiple lesions in an MRI, you want to understand the functional deficit zone around the lesion when you find that EEG is abnormal, or if there are additional secondary discharges in and around that particular lesion, and obviously functional integrity of the rest of the brain to prognosticate the post-operative long-term seizure freedom or other additional issues that patient might face. So I think just to summarize this in crisp manner, the FDG PET-CT as well as the ECD brain SPECT has been a very useful investigation for our team, and I think I have also got a great opportunity to learn from this entire team with respect to correlation of this. So always there is a correlation of EEG, the neuropsychiatry, in addition to the MRI findings, considering the nuclear medicine hypometabolism or hyperperfusions to find out the epileptogenic zone is the crucial crux of this entire practice of nuclear medicine use in the preoperative evaluation of epilepsy. I thank you.
Thanks, Shwetal, for a very nice talk explaining the use of various methods to identify the seizure focus and prognosticate. I think if Dr. Sangeeta's presentation is ready, we can go straight on to it, because I think we'll leave the discussion to the end. If she is not ready, we can discuss this presentation right now. Are you there, Sangeeta?
Yeah, I'm there. I will do it from the phone. I hope that's okay.
Your voice is coming very clear now.
Yes. Clear.
See, I'm doing it from the mobile. Okay, I'll just share my screen then.
Perfect. Yeah.
What is this?
You have to sign.
I just wanted to screen share the screen. That is not happening.
Yeah.
Just a second. Just a second. Share screen.
Yeah.
No. Share screen is here.
Yes. So just share. This is also done.
Yeah, that is done. Okay. Can you share my see my screen?
Yeah, yes, we can see.
Okay, fine.
We can hear you also quite well.
Yeah, thank God. Just a second, I'll just make full screen.
Press down on the at the right.
Yeah. Okay. Yeah, can you see now?
Yeah, yes, we can see. Yeah.
So basically, I've covered this slide.
You can present like this also, no problem.
Yeah.
We can hear you now.
Yeah, you can hear me, but my slides are not moving.
Moving.
Yes. Now can you? Okay.
Yeah.
Okay.
Yeah. They're moving.
Yeah. So all drug-resistant epilepsies, they say as per and they should be sent to this for epilepsy surgery evaluation at least every 3 years, because as Svetal said, PET scan has come, ictal SPECT has come, invasive, monitoring has come. So more and more patients can be suitable surgical candidates. Now, the main thing is I said, what does pre-surgical evaluation objectives are that rule out the pseudo-refractory thing, then define the electroclinical syndrome, establish what is the etiology, evaluate the medical treatment. It is always better that you try the medical treatment to the best, and then select an ideal surgical candidate who has a good congruous results. And most important thing, surgery should not result in any disabling neuropsychological or physical deficit. Goals of surgery, definitely freedom from seizure, no functional deficit. It should improve the quality of life and proves cost effective compared to the medical line of treatment. Now, apart from doing a routine thing, what phase 1 is, either you do, video EEG and MRI 3 Tesla, which we do, followed by that SPECT and PET scan, neuropsychological testing. Now, VADA, we are not doing as we have more of functional MRI available easily. And then you have an interdisciplinary patient management conference. This is very important part of the pre-surgical evaluation because the patient should be given a holistic approach that what is going to be, if someone thinks that IQ will change, my psychiatric all manifestation will change. So that may not change. So it is important to give realistic expectation to the patient and the relatives. And after that, if it is thought that it is not congruous, then you might have to go invasive, cortical stimulation or stereo EEG or other further evaluation. And so the non-invasive workup is consisting of a high resolution MRI, functional MRI, ictal video EEG, functional neuroimaging, neuropsychology, and psychiatric evaluation. So let's go to the MRI. Now, definitely 3 Tesla MRI should be a choice for any epilepsy patients who are thinking of, you're thinking of focal lesion, then don't go for 1.5 Tesla. And also the radiologist who is reporting this should also be an expert in the field of epilepsy and should have an insight into the epilepsy, because often it happens that the MRI which are reported normal by the routine radiologist, our epilepsy radiologist does find a focus when we tell them to search into a particular area. This will just give you an example. A 13-year-old boy who had a semiology was quite focal, having a left lower limb paresthesia and 3 to 4 episodes in a month with multiple 3 to 4 anti-epileptics. But 1.5 Tesla MRI done twice was normal. Ictal SPECT was normal. And in video EEG, there was clinical semiology was suggesting right parietal focus, but EEG did not show focal onset. So again, he was continued for an anti-epileptic drug, and then again he was reevaluated, and this time the EEG showed a focal features in right parietal, and then again the 3 Tesla MRI was done with telling radiologists very clearly to look for a leg focus in the parietal, high parietal area, because he had a sensory aura in the left leg. And then we found this focus here. So this shows very clearly that things which are missed on 1.5 Tesla can definitely be picked up on 3 Tesla, as it shows that 3 Tesla MRI could be 2.6 times better in characterization of lesions and more accuracy of lesions. Often the dysplasias in the temporal lobe which are missed by the 1.5 Tesla can be picked up on this. Another study which shows that almost in 65% of the patients, you may find a new lesion on doing the 3 Tesla MRI. Then comes the next, second is a video EEG telemetry. Definitely, this is really changing. The whole field has changed after this, and the treatment may change in almost 30% of cases. Even if they don't go for surgery, definitely this does have a more beneficial things. So as we all know, I think that patient usually is admitted to the hospital. Drug withdrawal is done by 30 to 40%, and then he's put on the. Usually, it's better not to do a full complete withdrawal of the drugs, because then the generalized seizures are more and the focal onset may be missed. After that, the invasive neurophysiology is whenever you have a non-lesional epilepsy, non-localized structural imaging, or you have a dual pathology or multiple lesions, atypical electroclinical syndromes, non-congruent result on the previous non-invasive workup, bilateral temporal onset or epileptic zone, impinges on the eloquent cortex, or first surgery has failed and you want to do again and a patient has a recurrence, then these are the times when you should think of doing a invasive neurophysiology. ECOG is one which will definitely help in getting things like dysplasias, which as neurosurgeons, we all know that it may be looking very like a normal tissue, the dysplastic tissue. So know the clear-cut margins, whether you've resected everything or no. I think doing an electrocorticography during surgery definitely helps in better outcome. So like you have this multiple spikes during before the surgery, and then post-surgery, when you do it again, you have a clear zone. And so getting this spike-free zone definitely helps us in more confident that patient may do better after the surgery. I think SPECT and this I will, I think SPECT, I only want to say one thing, that very alert video EEG technicians are required, well trained, because the SPECT infusion has to be in first 30 seconds. Otherwise, it may get generalized and you may miss the whole thing. The functional MRI, definitely, like this example of this patient was operated once, but she started having the seizures again after 1 year of seizure freedom. And then this was, we did the functional MRI, as the leg area could be near it. So it was just next to the foot area. It was here. So we went deep inside, because when we did the ECOG, the spikes were coming within this depth of the what was there. So there was some tissue left behind. So that depth, this was resected and the foot area was not touched. And then she, after almost 10 to 11 years, she has done very well, no seizures, and she's our Facebook friends too. Then comes the neuropsychology toolkit. Apart from doing a general IQ, the main thing is for temporal lobe, we need to check a verbal and visual memory, language, executive dysfunction, visual spatial function, and speed of processing. Speed of processing and all is other, definitely to see the anti-epileptic side effects, because topiramate and others may affect that. But what we are interested is that whether it has showing the right temporal involved, the visual memory test should be down, left temporal verbal memory test should be down. If the frontal is there, maybe frontal executive test have problem. And so this lobe-wise testing, which is done in this neuropsychology testing, helps us in localizing whether the same, what is the pre-op deficit. It is important to know, because if the pre-op deficit is not there and you want to operate that area, definitely patient is likely to get the deficit post-op. So if you decide that there might be a post-op deficit, then it is important that you tell the patients that what is going to be the post-op deficit, prepare the patient and then go ahead with surgery. But if the pre-op deficit, already the memory is down on the temporal lobe, whichever temporal lobe you're operating, definitely you can go ahead more easily and there will not be any deficit. It also helps them in assessing how the quality of life is improved, and important thing is that elicit the realistic expectation you have to give, that IQ is not going to change, and this behavioral problem may remain. And often it happens that we may not be able to do complete medication may not be stopped, and some 1 or 2 medication may remain out of 4 or 5. Also, sometimes you have to tell them that if you are going to remove the right temporal lobe, you may not be able to do the, like tailoring job or architecture job or things like that. So even that counseling regarding their future also needs to be done by the neuropsychologist. Psychiatric evaluation is also very important. Detailed psychiatric evaluation has to be done because there are often anxiety, depression, other things are associated with this. And it is important that you identify them, treat them, and then defer a surgery till we get a patient becomes better. So in our group, we always have a psychiatric fitness taken before the surgery. And post-operative also often, supposing a right temporal lobe also often has a behavioral issues coming later on post-op. So it is important they also do a follow-up with the psychiatrist after the often there is a normal burden of normalcy, like they suddenly become normal and the expectations from the relatives becomes more, and then they can't cope up with that. So then they start developing pseudo seizures and depression. So the psychiatric evaluation post-op is also very important. Contraindication, definitely genetic surgeries or minor surgeries or only nocturnal. And relative is the relative contraindication that you have some progressive neurological disorder. You have, I had a patient of MS who had a typical presentation of a TLE. And then when we evaluated, he was referred for surgery, and then we evaluated, it turned out to be an MS. So we didn't do surgery definitely because we treated him with immunosuppression. IQ less than 70 is for a relative thing. And supposing there are often mixed seizure disorders who have a pseudo seizures along with a true seizures, so it's important that you control the pseudo seizures first and then have a psychiatric witness and then go ahead with the surgery. Post-surgery follow-up, the patient should be kept, may be kept in the hospital till stitch removal, but nowadays we don't keep them. We usually discharge them on 4th or 5th day, and then they come back for stitch removal. Regular follow-up at 3 to 6 months. At 3 to 6 months, we do a repeat MRI and an EEG. And then EEG is done later on after 1.5, 2 years when we start tapering the anti-epileptic drugs. Neuropsychology evaluation is done at 1 and 5 years, psychiatric as and when required. And TDM is also done if required, and drug tapering usually after start 1 to 1.5 years of good control and a good normal EEG. Just to give example of a few patients, like a 4-year-old child who had a left focal seizures and a right hippocampal sclerosis associated with cortical dysplasias. And this was I can't show the videos in this because I've just borrowed Neeraj's laptop, so videos won't run. But these are the dysplasia which he had, and he was operated, though he was just a 4-year-old, but definitely earlier the surgery is better the outcome. That's beyond doubt, which has been already proven. And no seizures since 2011. He has also stopped following up with us. Another child of a 9-year-old child who had this confused and typical focal unaware seizures. And he also had sorry, I don't have a pre-op scan of this, but this I will show. This was an cystic encephalomalacia of a right MCA territory, and patient already had a left hemiparesis. So in this, the deficit may not much happen because there's already a left hemiparesis, and so the hemispherectomy will definitely was done because of the uncontrolled seizures, and his deficit did not worsen post-operatively. And for those patients who have this multiple drop attacks with thinned out corpus callosum after as a sequel of parenteral hypoxic insult, and who have a multiple scars on the forehead, these are the ideal candidate for drop, corpus callosotomy. So to conclude, not all patients with refractory epilepsy are a surgical candidate, but patients with focal refractory epilepsy are definitely candidates for surgery, but detailed workup is required, a team approach is required. And then if there is an ideal surgery candidate, the results are really satisfying and gratifying. So whenever such patients are there, do send them to a comprehensive epilepsy care center, and we may be able to make a difference in their patient's life. Thank you.
Thanks, Sangeeta. I think, that was a good presentation given the limitations which you had.
Yeah, sorry, I couldn't show the videos because
Yeah. No, but I think it went off well and you have been able to make your point. What I thought we should do is, Datta,
Yes.
you are going to be restricted to temporal lobe epilepsy, and the
Yeah,
first
yeah,
two talks have covered,
Yes.
you know, all other aspects. So
Yes.
can we just have a few comments
Yes, yes.
on the general, both the talks which you have had before we go into your
Yes, I think so.
yes,
Yes.
yeah, any
technical talk?
questions and comments most welcome.
Yeah. So I would like all the three speakers to make a comment each on both the talks, and then I have a few questions to ask. Dr. Kurwale, please. I think Sangeeta has emphasized very well that we need to evaluate many more patients than what is currently happening. And there are various ways, but I would start asking Sangeeta that if you have a patient who has a medial temporal epilepsy classic, you have a laterality and you can see it on ordinary MRI, do you need any more of these investigations at all?
No, sir. Only thing is at least EEG where interictal, even if we may not go for ictal video EEG, but at least interictal spikes should be picked up. And if you have got the history that there is a clear semiology which is there on history, you may not go for detailed video EEG. Why neuropsychology? Because if patient has not got the deficit, at least we should tell patient that you may get a deficit. So these two things are important.
So neuropsychology is important, even if you have a concordant good data with
yeah, because we have seen patients who are very intelligent. We don't find them deficit on this thing. So probably they may using a strategies or things like that. So it is so it often it doesn't go always hand in hand that MTS means you will have a deficit. So baseline if you have, and the patient's journey post-operatively becomes much easier if there is a guidance from a neuropsychologist.
Nilesh, what is your current protocol for the medial temporal epilepsy patients?
Almost the same what is described by Dr. Rawat. We follow all these things. I mean, proper video EEG, proper neuropsychology. We get PET scan in almost every patient of temporal lobe epilepsy. Only thing is we do not do functional MRI or WADA in any of the patients of classical mesial temporal lobe epilepsy.
Yeah, they won't need, definitely.
Yeah. So apart from that, more or less the same thing, sir.
I appreciate, but do we really need to have a video EEG and I mean neuropsychology, yes, but do we really need to have a SPECT and video EEG in all these patients? Dr. Dhakoji? Amit, are you there? Milin?
Amit, unmute yourself. Amit, unmute.
Yeah, can you hear me, sir?
Yeah.
Yes.
So many times what happens is the mesial temporal sclerosis can be secondary and there can be a hidden lesion somewhere else. And video EEG will accurately help us localize that lesion. And sometimes we have seen surprises that the video EEG localized it to a parietal lobe and there was a calcific granuloma there. So we should be very careful, and it is radiologically very difficult to differentiate between a primary and secondary mesial temporal sclerosis. Dr. Dattatreya Muzumdar will agree with this. So video EEG, I feel as a part of classification of seizures, and as a part of protocol of any comprehensive epilepsy surgery program is important, and I feel it should be done even if it is a classical mesial temporal lobe epilepsy.
So Dr. Sangeeta, today, where are you using the nuclear various imaging techniques? What are the current indications apart from multifocal disease?
Madam, unmute yourself. Unmute yourself. Madam, unmute. Okay.
Yeah.
Okay.
So what routine temporal lobe surgeries, it's not required often, but whenever we have that interictals or other, you have which is not as localizing to a very small area, and we find that EEG is showing a little wider area than what the MRI is showing, then that's the time when we always go for a SPECT or PET scan first. And then if there is a bilaterality and we want to see ictals, then we also go for an ictal SPECT.
Dr. Milind, what is the current protocol for getting nuclear imaging done at your center?
So to give an idea about what you asked earlier regarding whether video EEG would be done, the answer to that is yes. We would do a video EEG for almost every case, even if we find interictal discharges on the interictal EEG. And there is a concordance with the imaging. We would not necessarily go on to do a PET, but PET becomes the first imaging as far as nuclear medicine is concerned to look for hypoperfusion. Though SPECT has been there with us much earlier than PET, but availability wise, but at the moment PET is the first thing that we would prefer to. And otherwise I would completely agree with what has been expressed by Amit as well as by Sangeeta and Nilesh, that we would think in terms of not doing WADA anymore. I don't remember doing a WADA for the last so many years at all. Whether it is, frankly, I don't remember doing WADA for even extratemporal epilepsy for many, many years now. But one thing which is probably not mentioned was interictal imaging as such. So that I would just like to highlight. The interictal imaging does play a particular role as far as which was not mentioned by Sangeeta.
Interictal imaging.
Interictal SPECT, you mean?
SPECT. No, I skipped the PET and SPECT because
PET, interictal PET would be the choice.
Yeah, I skipped that slides because talk.
Correct.
Yeah. Okay.
So I think with this background, if all panelists are going to stay, we can probably go on to Dr. Muzumdar's talk and then talk more specifically on mesial temporal lobe epilepsy. Please go ahead, Dr. Muzumdar.
Yeah. Can you see my
As
screen?
everybody knows, Dr. Muzumdar is professor of neurosurgery at KEM and is very active in epilepsy surgery in Mumbai.
Can you see my screen, sir?
Yeah.
Thank you, MCNS. Thank you, Dr. Sankla, Dr. Devpujari. And I'm grateful to all, to Madam for coming and giving her talk on pre-surgical evaluation that sets the ball rolling. And obviously PET, which was the nuclear medicine studies which Shwetal has mentioned, which has got an emerging role, and we have to understand a lot more things before we really come to a certain conclusion. And obviously the panelists who are experts in their own way in epilepsy surgery. So I would just start with the drug refractory mesial temporal lobe epilepsy surgery. And this is what is my experience, because I understand that this is being there for quite some time. And we started this comprehensive epilepsy care center way back in 2000. You can see that it's quite a journey with Dr. E.P. Baruja till Professor Rawat now spearheading the program. And we have this inaugurated by Charles, none other than Charles Polke and Colin Binney in 2000. Dr. Piyusha was the head of neurology at that time, and we have the Center for Neuropsychology with Urvashi is spearheading, and it is absolutely an important component of our epilepsy surgery program. And I want to stress about collaborative epilepsy surgery. Unless there is collaboration, nothing will work. So it has gone back way in the 17th and 18th century, where Jackson and Horsley used to do, carried forward on the Canadian side by Penfield and Rasmussen. So I think collaboration is the key. And here we have the team right from Professor Rawat, who is the team leader, and to Shwetal, who is the nuclear medicine expert. We have about 22 years of experience now, 650 plus cases, and long-term follow-up of 10 years in about 200 cases up till now. And the overall results have been very gratifying in terms of seizure freedom, seizure control, and quality of life. We have compiled our entire experience into the International Journal of Surgery, which is an elsewhere publication, and it has got an impact factor of 13. So it is one of the quite cited journals in today's field. The Indian scenario is well known. I will just brush upon that. There is a lot of scope for epilepsy surgery. Maybe we have just iceberg still, and we need to do certainly more, which has been well elaborated by Dr. Radhakrishnan in his survey, and he has published it in Caesar in 2015. So at least in our country, we need a lot of epilepsy surgery programs to go and carry this thing forward. So first of all, when we say about mesial temporal lobe surgery, I think for the neurosurgeon who is interested in epilepsy surgery, who wants to do epilepsy, we have to understand the neuroanatomy and the neurophysiology, because unless that is done, an effective surgery and an effective outcome may not be possible. So we have to understand that the mesial temporal lobe structures are intraventricular and extraventricular. So intraventricular, the most being hippocampus and the amygdala, and extraventricular being the uncus, parahippocampal gyrus, and the dentate gyrus. And you can see in the middle figure that the hippocampus has got the zones CA1, CA2, CA3, CA4, which is connected by the subiculum to the parahippocampal gyrus. And subiculum is the most inferior component of hippocampal formation. Each one has got a tremendous role, and as you see, subiculum is useful in working memory. It is used in the HPA axis, and on the left, in the down screen, you can see that how actually a MRI of a mesial temporal lobe hippocampal sclerosis would look. So if you see on the arrow, you can see on distinct on the right and the left. The right is the temporal lobe is hugely atrophic. You can see the sulcal spaces, that gyra has been atrophic, the temporal horn is dilated. As compared to the opposite side, where the hippocampus has got bumps, you can see that the hippocampus is flattened out. It is low in volume, and you can see the amygdala, which is also a little bit shrunken. So this is the shrunken temporal lobe, and as you see, the hippocampus is the hippocampal or the mesial temporal lobe structures include the hippocampus has got role in episodic memory. So all the memory encoding, episodic memory, and the spatial organization, consolidation of memory all occurs in hippocampus. So we have to know the hippocampal anatomy in quite detail, as I've just shown a specimen on the right side, where you can see the hippocampus, the head of the hippocampus, body, tail, the amygdala portion, the entorhinal cortex, and the uncus. This is the amygdalo-uncal complex at the anterior inferior aspect, the hippocampus, and the choroid plexus. The choroid plexus forms an important limit for the resection. This is the parahippocampal gyrus, inferior temporal gyrus, and so on and so forth. So this has to be known before we encounter any epilepsy surgery. Amygdala has got also an important structure where it is composed of many nuclei. And we, as you know, that we cannot do a complete amygdala resection. We have to leave the medial part. And the amygdala has got a lot of functions. It is connected with the limbic system, the prefrontal cortices, the sensory motor cortex, and it has got, it is the emotion center. So all the emotions and fear and all the vision, smell, hearing, all the decision making, attention, all this is included in the amygdala. So amygdala, hippocampal anatomy, and the neurophysiology has to be understood quite well. Now, the entire gamut of epilepsy and epilepsy surgery for the medial temporal lobe is in conjunction with the Papage circuit or the limbic system. Now, as you see here, what we do in essentially in medial temporal lobe surgery is resective disconnection. So we have a structural abnormality which we resect, and in effect we are doing disconnection. What are we disconnecting? We are disconnecting the Papage circuit. So the hippocampal formation is connected, hippocampal formation with the dentate gyrus. It is connected with the fornix and the mammillary bodies. From the mammillary bodies, through the mammillothalamic tract, it goes to the anterior thalamus, and from the anterior thalamus, through the internal capsule, it goes to the cingulate gyrus, and from the cingulum, then it comes back to the parahippocampal gyrus. Now, you can understand that the subiculum, which I just mentioned, there is an internal pathway and an external pathway. The internal pathway of the limbic system is what I just mentioned, from the hippocampus subiculum directly through the fornix, mammillary bodies, and to the thalamus and the cingulate gyrus. But there is an external pathway where from the cingulate gyrus through the cingulum bundle, it comes back to the parahippocampal gyrus. So if you can understand that not only the hippocampus, but the parahippocampal gyrus, amygdala, fibria, all are important. Concus and the amygdala are all important aspects of mesial temporal lobe resection if we have to do a disconnection. So in effect, nowadays we are doing the DBS is being proposed for mesial temporal lobe surgery. The anterior nucleus of the thalamus is being proposed. So we are evolving further from resective disconnection. And to understand it, the emotion, memory, and seizures go hand in hand. So that's why if you see that an epilepsy patient is not a single patient. So it is a patient who has got seizures, who is seizing continuously, but has got a lot of psychosocial issues because of emotion, memory, and which has been alluded to. That's why we do the extensive investigation of neuropsychology, psychiatry, and nuclear medicine. This is because the circuit is basically the same. And when we do this disconnection, we have to be sure that the psychosocial, the psychological, and the psychiatric parts are taken care of properly. So chronic surgical epilepsy, we need to definitely understand it because it has got huge implications as far as the treatment, ICU admissions, neurology visits, the socio-economic, and there are a lot many comorbidities. So basically, your interruption of the resective disconnection surgery in the middle temporal lobe also affects these aspects, the comorbidities as well as although they are not direct, they are indirect effects. So all these things have to be understood before we subject the patient to surgery. It has definitely been proven beyond doubt that in 2001, the London, Ontario study by Sam Weeb for temporal lobe has shown a clear-cut efficacy of surgery over medical treatment. And now that same was echoed by Jerome Angel in Los Angeles. So we have to do early surgery in MTS. So why do we have to do early surgery in MTS? Because apart from the freedom of seizures and withdrawal from the drugs, we avoid SUDEP, we avoid kindling phenomenon. Kindling phenomenon is that the focus can shift to opposites and it can become bilateral MTS. And in effect, if we do early surgery, it gives them enhanced quality of life. However, we have to also be sure of the burden of normalcy where this patient need to be integrated back into the society. So pre-surgical evaluation, I will not go into the details. Already a good clinical history and exam is absolutely essential, and the surgeon has to be involved in each and every aspect of the pre-surgical evaluation to understand the situation better. So visual perimetry has to be done because sometimes these patients do not have a silent visual deficit which might go unnoticed. So I will add visual perimetry from the surgical side that needs to be done to evaluate the medial temporal lobe epilepsy. This has been already alluded to. So I'm going to talk about MTS and MTS plus. So this MTS plus would involve dysplasia and lesions which are associated with MTS. So this would cause an MTS. This also needs to be understood how to handle this, because it is not that we are just going to operate the ganglioglioma and patient will be seizure free. No. So we, as an epilepsy surgeon, we have to understand these lesions in concurrence with the MTS, and then whether to resect, not to resect, that I will just come in a minute. So what I have understood about whatever MTS I have operated is that there could be isolated MTS. There could be MTS with the polar gray-white cortical blurring. It may not be dysplasia, or it could be a polar dysplasia type 1, or it could be an intensely sclerotic hippocampus, or it could be MTS plus, which is associated with lesions, and bilateral MTS. This is the MTS spectrum that a surgeon would encounter in his epilepsy surgery practice. So here is one example where there is hippocampal sclerosis with type 1 anterior polar dysplasia. You can see diffuse cortical dysplasia, the whole temporal lobe. You can see, compare from the temporal lobe from on the right and the left side, you can see that the whole temporal lobe is a little bit more bulky. You can have bilateral temporal, medial temporal lobe sclerosis, or you can have a severely sclerotic or dysplastic hippocampus, which is another surgical entity which needs to be dealt with very carefully. So you can see the intense flare signal on the hippocampus, which can be an isolated sclerotic hippocampus. You can have MTS with completely temporal lobe atrophy, or it can have a mammillary body atrophy where the limbic system is atrophied because of the continuous seizures and the anticonvulsant medication. Dysplasia. So we encounter dysplasia, focal cortical dysplasia in the middle temporal lobe. So there could be a severely dysplastic hippocampus, or there could be diffuse cortical dysplasia, or I just mentioned hippocampal sclerosis with dipolar dysplasia, and the amygdala uncal mass lesions. This also form a separate group of lesions apart from the MTS. So sclerosis, amygdala uncal lesions, mass lesions can also cause hippocampal sclerosis. Now, when would we consider amygdalohippocampectomy? So either there is a lesion has an anatomical proximity of the lesion with the medial temporal lobe structures, there is associated cortical dysplasia. Now, side of the lesion matter, right or left, and neuropsychology, whether it's intact or impaired. Intraoperative ECG recording on the hippocampus need to be done sometimes. We have to study the hippocampal architecture, and obviously our surgery has to be tailored according to the socioeconomic status of the patient and as well as the occupational patient. A high functioning individual, an executive, we have a different requirement than a farmer or a person who is unskilled. So visual temporal lobe epilepsy surgery, as I mentioned, it is basically resective disconnection. And we always go in for a standard ATL, that is amygdalohippocapectomy and lateral temporal lobe neocortical dissection. We do not evidently favor selective amygdalohippocapectomy. There are many reports in the literature where it's supposed to be effective, but there is no significant advantage in seizure outcome, memory, or language affection. And obviously, functional disconnections of the temporal lobe are also known, where you just do transit the hippocampus, but do not remove it. So transactions of the hippocampus are also known. Our goal is complete seizure freedom with no added neurological deficit. We have obviously the benefits of surgery are well known, so we have improvement in the seizure freedom as well as the drug withdrawal. Special situations. So now with the awareness of epilepsy going on, there are young women who are considering marriage. Sometimes it's a precondition for divorce. Sometimes patients want to get pregnant. They want to pursue higher studies. There is a prerequisite for professional courses and higher executive functioning in certain things. So these patients, this special situation, the MTS has to be addressed first before all these things can be taken forward. So apprehensions, we have apprehensions. When the patient has got intact memory profile, we need appropriate counseling, cognition, intelligence, language. We do functional MRI for dominant lobe lesions. And this is the scalp incision. Usually I usually take a small scalp incision, which is just limiting the superior temporal line. And you can see the superficial temporal artery and the frontal branch of facial nerve need to be segregated. I usually take incision directly on the temporal fascia and reflect and expose the muscle and reflect the muscle anteriorly and inferiorly. The craniotomy is basically an anterior and a basal exposure, anterior inferior basal exposure, because I need to see the temporal pole into the view always. So I use the middle temporal gyrus approach. You can use trans-Sylvian approach, this Jasargil use. You can use the inferior temporal gyrus approach, or you can use the middle temporal gyrus approach. I use the middle temporal gyrus approach. I don't expose the Sylvian fissure always. I safeguard the vein of Labe. I take care to see that the optic radiations at the Mayer's loop at the posterior end of the hippocampal tail resection are safeguarded. Obviously, this is limited resection of the lateral temporal neocortex. We have to be careful on the left side, 4.5 from the pole, 5.5 on the right side, which is for any other temporal lobe surgery. I usually do a subpile R block resection and no transgression of pyometer. This is the crux of surgery. Minimal retraction of the temporal lobe and safeguarding of the anterior channels. So here I would just put a small video, like a 2-minute video. So you can see here, this is the middle temporal gyrus approach. This is a highly edited video. Please pardon me for that, because this is a 2-hour surgery which has been compressed into 2 minutes. So I just go take a middle temporal gyrus incision, open the temporal horn, which this is the fact, and I can, as soon as I open the temporal horn, then I go anteriorly. The amygdala incision is like this. So the inferior sulcus of the insula and I go identify the entorhinal sulcus and free the amygdala from the outer third of the amygdala, from the most medial part from the outer part. So medial part of the amygdala is in close connection with the basal ganglia and the claustrum. And there is an arbitrary line of resection. There is no definite line of resection. You can see that the amygdala is separated, and I can see the basal pia. When I see the basal pia, this is the entorhinal cortex, which is in line with the insula. Now this is the hippocampus, head, body, tail. I take the incision on the tail. This is the choroid plexus, and my whole line of this thing is that I take the incision on the tail. I use the suction as a dissector. So it's a technique which I do. And then from there, from the tail, I enter into the parahippocampal gyrus. So from the tail, at the level of the trigone, I identify the pia basally. You can see that suddenly you can, in no time, you can see that the pia is there. So you can see that no transgression of pia at any period of time. So then I enter. This is actually the hippocampus and the dentate gyrus. So there, hippocampal sulcus. Then I come into the hippocampal sulcus. The hippocampal sulcus is a sulcus between the hippocampus and the dentate gyrus. And you can see that I am now into the hippocampal sulcus, which has respecting the arachnoid and the pia. So from there, I just lift the hippocampus from the hippocampal bed. Posteriorly, I would encounter below the pia, you can see that the PCA, the P2 segment is there below the pia. The pia should not be exposed, as I was mentioned. And anteriorly, as I come in the hippocampal sulcus, I would see the anterior coronal artery, the optic nerve, and the oculomotor nerve. And see, you can see that this is a tent, and the anterior coronal artery and the branches and the oculomotor nerve will be below this. So from that, the hippocampus is completely disconnected, as you see. And now I will be disconnecting the temporal lobe. As you see, I'm disconnecting the temporal lobe from the pial surface, which includes the parahippocampal gyrus as well as the fusiform gyrus. So you can see that we use intraop ECOG for all cases. It helps us to extend or limit the resection. We avoid chasing the spikes. Now, hippocampal intraop ECOG is not a predictor of seizure outcome, but it does have a positive influence on the seizure freedom in long term as compared to lesionectomy without ECOG. And this is a temporal lobe specimen. You can see that this is an R-block specimen which we have removed. We can clearly see the hippocampus, the parahippocampal gyrus, and the temporal lobe. Post-operative course, normally this patient usually have a transient fever, some meningism, headaches, some subgaleal swelling at the operative site, which clears within few days. But the complications can be disastrous if they occur. And we have 2 patients who have developed visual deficit. One patient developed transient hemiparesis. Sometimes the psychosis can worsen after surgery, and sometimes the patient can have a personality change. So here is a sequelae after surgery. You can see that there is a bright signal on the T2 on the flare, which suggests that there has been some venous affection. So we have to be careful about that. Sometimes you can see that infarct can occur. You can see the infarct in the internal capsule and as well as in the posterior temporal lobe. So this could occur time to time. Suppose sometimes the anterior coronal artery can go into spasm, or there could be minor perforators which should come into your resection margin. So that needs to be taken care of, and you need to remain subpial as far as possible. Surgery is safe in experienced hands. Water rate is very less. Hemiparesis is less than 1%. Visual field deficit, as I just mentioned, that in literature also the visual deficit is about 17%, and at a specific angle, 10 degrees from the center. So this can be asymptomatic. Normally patients do not complain, but if you definitely take a perimetry, we do post-op also. And sometimes there are surprises, but most of them do not have any visual deficits, either subjective or objective. Persistent post-operative seizures. Then what happens if the patient develops persistent post-operative seizures? It is not synonymous with reoperation. A residual hippocampal tail can remain, but it does not necessarily mean resurgery. In fact, the residual tail helps in reorganization of memory. So if there is a persistent post-operative seizure, you have to look at whether patient has sometimes subdural hemorrhage can cause it. Sometimes residual mesial temporal structures can remain, or the epileptogenic zone is more extensive in the posterior temporal neocortex. Sometimes pathology may be non-specific, or there could be contralateral focus, or sometimes a low-grade tumor can be missed. So these things should be ruled out before we say that the surgery has failed, or we need further evaluation for to know what is the cause of the seizures. Advantages, as I just mentioned, we are not looking, as everybody knows, that seizure control is good for unilateral cases, about 80% at 1-2 years, but we are looking at 10 years rate. And if we identified about 107 cases at 10 years, where our seizure freedom rate was 65.4%, and drug is out of this 56% were drug free. So you can imagine that what appears at 1 year, 2 year may go down over a period of 10 years. We have a mean follow-up of 11.3 years. In bilateral MTS, you can expect to have 50 to 60% of seizure freedom. So we should look at long-term seizure freedom and drug freedom in cases of MTS, and not at 1 or 2 or 5 years. Now, I will go a little bit away from now MTS to lesionectomy along with whether to remove the mesial lobe temporal structures or not. So what are the aspects? So if the lesion is close to the mesial temporal lobe structures, most likely you will need an amygdala hippocampotomy. If intraop ECG shows intermittent or polyspikes on hippocampus, you need to remove the hippocampus. Right-sided lesions with normal or abnormal memory profile, you become generous with a right ATL. Or there could be an hippocampal structural abnormality like a microdysplasia, or sometimes the cortical dysplasia imperceptibly blends away with the mesial temporal structures. I would do only lesionectomy if I see a normal white matter around the temporal horn, intraop ECG does not show any epileptiform activity, and if it is a left-sided lesion with intact memory profile, that I would do only lesionectomy. Decision is taken in a consensus multidisciplinary evaluation meeting, and sometimes we have to take an intraoperative decision. So here is a arachnoid cyst where we had to do lesionectomy with ATL because the arachnoid cyst was removed and it was the mesial temporal lobe structures were spiking. And you can see sometimes there is a left parahippocampal gyrus low-grade glioma with mild hippocampal cortical thickening. There was intraoperative hippocampal activity, memory was affected. We did an ATL. This is the post-op MR where we can remove the entire mesial lobe structures along with the lesion. Sometimes there could be right temporal lobe heterotopia with hippocampal dysplasia. Intraop ECG shows no activity in hippocampus. There is normal memory, so we just need an ATL. Left parietal. Sometimes we have to do single stage with two different incisions. So there was a left parietal occipital FCD with MTS. So did a FCD excision in the parietal temporal lobe as well as an MTS in the same sitting. Sometimes there could be epidermoid, intraop ECG showed spikes, memory was impaired, removed the epidermoid and did an ATL also in addition. So here you can see the post-op where the epidermoid as well as the mesial temporal lobe structures are removed. Amygdalo-uncal ganglioglioma, memory impaired, right side memory impaired, amygdalo-uncal lesion, do a generous temporal lobectomy. There's a parahippocampal gyrus tumor, bulky hippocampus, memory was normal, we can do a temporal lobectomy. So sometimes the lesion is away from the hippocampus and the hippocampal recordings are normal. So that time we may just spare the hippocampus, or sometimes if we get an intraoperative of ECG spikes on the hippocampus, we have to talk to the relatives and maybe we need to remove the hippocampus. But mind you, if we just remove the calcified lesion, we might have to undergo a second stage surgery, which is very difficult for our patients to understand and comprehend. So we need to take a very objective decision whether we need to knock off the lesion only or in addition to that mesial temporal structure. Sometimes there could be a midbrain glioma, memory is impaired, and in this case, obviously the midbrain glioma was partially resected, and then because there was patient had come with persistent with seizures, we had to do a ATL in addition as well. Superior temporal gyrus DNET, you can see that hippocampus was normal, memory normal, but intraop ECG spikes were seen. So we did the superior temporal gyrus DNET was excised and an ATL was done in addition. Only lesionectomy, sometimes as I told you, if there is just an amygdala low-grade glioma, hippocampus normal, intraop ECG normal, only lesionectomy. Here you can see that the spikes receded after we just removed the lesion. without the hippocampal removal. Left side, as I said, left side memory was mildly impaired, amygdalo-oncor low-grade lesion, intra-op ECG was normal. So here, since it was left side and the memory was mildly impaired, hippocampus was normal. We just did a lesionectomy and did not resort to a complete ATL. Fusiform gyrus cyst, hippocampus was normal, memory normal, no intra-op ECG spikes on hippocampus. So we had reasons just to resect the cyst and not do an ATL. Inferior temporal gyrus, low-grade glioma. Similarly, if the intra-op ECG is normal, hippocampus is normal, memory is normal, we just would go for an L. But we have an objective evidence why they are not removing. So lesions with mesial temporal lobes epilepsy should undergo early pre-surgical evaluation because the results are quite gratifying and surgery is safe and effective in experienced personnel. There are reports of is well established in literature that you can do early surgery, the results are quite gratifying and almost the patient can be seizure free in the long term. We have our own experience from AIMS where Sarat Chandra et al. His group has published in New England Journal of Medicine, clearly shown that lesions with medial temporal lobe lesions should undergo early surgery with the gratifying outcome. So I think the quality of life is better after if the surgery is offered early. There is a controversy if there is a dominance side, whether if it is a stable lesion with controlled seizures on a single AED, intact cognition, verbal memory. These are gray areas where we still might just wait and watch and then keep the patient under close follow-up. Complications, this is what I would say the domain shift. We evaluated the quality of life and shifts in total score. So on the long term post-surgery, mood, interpersonal relations, patient getting overprotected, all these things showed a good positive shift towards the right side. Bilateral MTS is another big issue, and most of the time we have used our non-invasive evaluation to the maximum. We have experienced about 35 patients where we have used purely non-invasive methodology. And in the setting of limited resources, non-invasive pre-surgical protocol can be used successfully with a proper patient selection. So the determinants are interictal and ictal EEG and symmetry of hippocampi. We go with whether there is an asymmetric hippocampus and where are the interictals and the ictals coming from. So with that, we have evaluated 35 patients where on the EEG and the memory, definitely with our evaluation protocol, we have found that we can operate only on one side, but our seizure freedom control rates are in the range of 50 to 60% with a non-invasive protocol. There are palliative procedures which are also described for the medial temporal lobe surgery, which are in evolution. Neurostimulation is there, image-guided surgery is there, radio frequency ablation is there, which are still yet to come into the standard of care. And obviously, the cost of surgery in a public hospital is much less than what we do offer in a private setting. Thank you very much.
Thanks, Datta. I think you have covered most aspects of medial temporal surgery. I would just transmit some of the concerns which Dr. Kishore Chaudhary has raised, and I also had one question. You mean subpile resection of the whole hippocampus, or you're trying to say that it will be you will try to preserve the arachnoid layer?
No, it's a pia. So above, I don't need to see the vascular structures or the midbrain or the coronal arteries. I don't want to expose them. So it is basically a subpile resection. So what I showed you in the video was the pia matter and the basal pia. So this has to be respected. Sometimes if it is in a sclerotic hippocampus, it is extremely adherent, and sometimes you have to take your own time to sort of use small micro dissector to separate that pia, and we have to be very careful at that time because sometimes some perforators can get affected if the hippocampus is very sclerotic. So barring that, if the hippocampus allows me to do that subpile dissection, I do completely subpile en bloc.
The second question which I had was to do this gentle dissection. Do you use ordinary graduated suction or use Kusa as well?
Can I leave if there are no questions for me?
Madam, you can. Madam wants to leave.
You would like to say something on this?
No, madam.
No.
You want to leave?
I wanted to say,
Okay,
I'm in
thank
the
you very much.
conference actually.
No, thank you very much for being with us and your talk.
So if there are no questions for me, then I can leave. Yeah. No, thank you very
All the
much for calling
panelists,
and
if you
having this.
allow her to go, she would be. Anybody has any question for Dr. Sangeeta?
No, let her leave.
Okay, thank you, Sangeeta.
Thank you very much. Bye.
The second question which Kishore has put forward, if you want to ask Kishore, is that do you do this with your gentle keyhole suction graduated, or do you do it with KUSA and
yeah. So I would not use any KUSA. As everybody knows that at KEM we are trained to use suction in the right hand. This has been completely contrary to what is I see in the West and even in the rest of India. So that has been given to us by Professor Pandya and Professor Goel and everybody. So we have grown. So yeah, so we use, I won't say it is a suction, it's a controlled kind of a suction that I use. And over a period of time, we have trained to use that keyhole where to completely zero the suction if I'm dissecting something or, I'm peeling off something. So at that time, it's a completely zero suction. So this is an individual way. So it is not necessary. So you can do many roads to Rome. So this is the way I use it. So I think whatever methodology you use, you have to be careful at the pile junction. So that is what I would say.
Appreciate that. I think all the three panelists, please make a comment and ask question to Dr. Datta on the technical as well as the other matters he has raised.
So very nice presentation, Dr. Mujumdar, and very nicely you have demonstrated the anatomy and techniques and good surgical video also. So I would like to ask how do you go about amygdalar perforators? Because if we injure them, we can have infarcts in anterior limb of internal capsule and caudate nucleus. So for the beginners in epilepsy surgery, there might be in the audience. So how would you give them a word of precaution for amygdala resection? And what is your superior margin for amygdala resection?
Yeah. So basically, amygdalo-uncal complex is what needs to be removed. So what I would do is, there are two ways to do about it. So you have to see that the amygdala part, there is a medial third and an outer 2/3. Okay, the 2/3 of the amygdala nuclei, the medialmost nuclei is concerned with olfaction. And the lateral nuclei, the central, the lateral, and the basal nuclei are concerned with the limbic part. So we need to resect that amygdala. The medialmost amygdala needs to be protected. Now there is no anatomical border which differentiates amygdala from the basal ganglia. So that has to be very clear cut. It's an arbitrary line. So what an arbitrary line is, I see the sulcus of the circular sulcus of the insula and the circular sulcus of the sulcus of the enteroanal sulcus. So that is one, and I usually use the inferior choroidal point. The inferior choroidal point leads me to the circular sulcus of the insula and leads me to the enteroanal sulcus and also opens the hippocampal sulcus. Now on the lateral aspect, the amygdala bulges into the temporal horn. Now, when we go outside the temporal horn, there is an arbitrary line which joins from M2. So we have to identify the middle cerebral artery through the pia, M2 to the choroidal point, the choroidal tip. So you have to remain within that line. If you transgress that line medially, you might enter into dangerous areas. So when I'm outside the temporal horn, I use that, I don't cross that line, the inferior choroidal point to the M2. And within the temporal horn, I use the insular sulcus joining the enteroanal sulcus. So that what happens is, I remove the parahippocampal gyrus. I also have a good view of the uncus and the amygdalar nuclei, which I was just talking about. So that gives, and I remain subpile. Again, I don't go outside the pia.
Yeah, so very nicely explained. So the anterior limiting sulcus of insula can be seen when you subpile suck the superior temporal gyrus, and from there you can lead to the inferior choroidal point. Very nice, very nice.
Nilesh?
I have you mentioned the use of ECOG.
Yeah.
Frankly, how important do you feel is the use of ECOG if you're planning to do a standard ATL? And really, is there any added benefit in doing an ECOG, particularly on the dominant hemisphere, when you have decided on the limitation of a resection?
Yeah, thank you. I think, Milind, this is a very important question. Now, if you consider ECOG, ECOG is not mandatorily used for a standard ATL all over the world now, except few centers in MNI, and where they use a lot of investigative modalities, they are using ECOG still. Considering our exposure here, why we use ECOG in all cases is, if now suppose there is an isolated MTS and there is, I'm sure that there is no FCD anywhere in the lateral temporal lobe or in the mesial temporal lobe, I may just go, I may avoid using the ECOG. But in our situations, most of the time we have found that there are lateral neocortical foci or there is some polar FCD. Now, in those cases, I use ECOG not as a definitive thing, but it gives me a comfort. It also helps me to identify the spikes initially. Later on, if the spikes go away, I have something to rest upon, although I'm still, the disconnection may not be complete, So ECOG is used in all cases. We use it in all cases just as a guide. So I would say that it is not a predictor of seizure outcome at all. So that's my take on it. It is useful kind of a investigation to use it. And especially if there is an FCD, I've seen that whenever I remove the entire temporal lobe and obviously use the pre-resection ECOG, and if I put a post-resection ECOG, I might have missed some dysplastic tissue where it fires very significantly. And I have resected the tissue and I got ECOG silence. So that is one case where I found that, this has helped me. Having said that, most of the time, after clearing the temporal lobe of completely the temporal lobe is resected, superior temporal gyrus, middle, and everything. Still, I find 5 spikes in the F4, C4, or FC3 region. Now, those are fronto-central spikes, which are beyond. And I know that, we are not going to chase that. But that is just we document it so that, for academic purposes, or you can say, I want to know, actually, we are studying now that what happens to these transmitted spikes, F4, C4, FC3, in the long term after mesial temporal lobe resection, whether they reduce, they go away, or they are there, or if there is a different foci up into the, in the the extratemporal region, that we are just evaluating. But certainly the ECOG used in our cases gives you certain kind of a guide. So I would, our data is still in evolution, so I would like to know in the future. But certainly we don't chase the spikes. So if I have minute spikes which come infrequently, we would not do extended resections. That is for sure. So that we know where to stop and where to just continue with the ECOG.
Any comments, Milind, on this?
No, I don't necessarily use ECOG. One reason why I actually end up using ECOG is to try and put some depth in the hippocampus.
We are talking of either an extended lesion or a dysplasia. We're not talking of only MTS then.
Correct. So that's precisely the question, that if you're talking about a standardized ATL, which you don't really want to, you're not debating about anything else. And then frankly, ECOG by itself becomes, as you said, more for academic purposes.
Yes.
And quite often we'll end up putting an electrode into the hippocampus in cases where we have our own doubts, but we don't end up using an ECOG.
Your comments, Nilesh, question? You are muted, man.
Yes,
you need
Nilesh
to
is
unmute
muted.
yourself.
Oh, I have more of a question to Dr. Muzumdar.
Yes.
So do you remove or how far you go on a superior temporal gyrus on the left side if you have a left MTS to operate? Yeah. And another just a very routine and question, but as everybody is there, how far posteriorly you go?
So right side I'm quite generous, 5.5. Left side 4.5. And usually I avoid going to posterior temporal regions completely. I might just leave it at that, So superior temporal gyrus 4.5 from the temporal pole on the left side, 5.5 on the right side.
I prefer to go between the sulcus of middle and superior temporal gyrus. Do you always take superior temporal gyrus for MTS?
No, sir. What I do take, because the reason I do take is because I don't open the Sylvian fissure, so I'm always comfortable coming from the brain surface into the pia, because then I know that I will not injure any vessels or perforators or anything. Now, having said that, the reason we remove go after the superior temporal gyrus is that I don't know, the epileptologists usually say that there are a lot of lateral neocortical foci which can be left behind. And since we are doing only one stage, one shot surgery, and considering our class of patients where it is very difficult to convince them in the future, if suppose something remains there and in the post-operative setting there is a seizure and some part of the superior temporal and middle temporal gyrus remains, we are in a fix. The surgeon is put high up in this thing, So over a period of time, I said, okay, I will completely remove this. I don't want any further problems in the epilepsy group meetings that this has been left behind, that has been left behind. Okay, there is either this could have been resected. Then there is radiologist to comment upon that. Then there is, it is surgeon versus the rest. As everybody, all of you must be encountering that. So I'm very generous on the superior within the limits. I'm generous for the superior temporal gyrus. I expose the vessel subpile.
We have all forgotten to ask any questions to Dr. Shwetal Pawar. Anybody has any question? She's with us still, I suppose. And then.
Yeah, I have questions for Dr. Shwetal. She also had a nice presentation. So many times along with in mesial temporal sclerosis, along with the temporal lobe, we find hypometabolism in thalamus or the opposite cerebellum. So have you found it regularly, and what is your take on that?
Yes, yes, quite a few. Actually, there is hypometabolism in various areas. It has to be correlated, with the MR findings as well as the EEG findings. But especially thalamus and other cerebellum being involved, we would like to consider vascular involvement in these, because that could be a reason for this type of opposite-sided cerebellar involvement or even thalamic involvement. Obviously, one has to search for any lesion with the MR as well. And if with the history also playing an important role in this, but not just hypothalamus and cerebellum, but we have seen a lot of other lobal, quite often with frontal or parietal, which could be isolated separate hypometabolism regions. We do report them, but I think they are only considered of clinical significance if there is any additional findings seen clinically or on MRI or on EEG. So they are noted down, and I think they are revisited. There is still yet a lot to understand about these hypometabolisms being there. So these are considered as a background at the baseline, and I think if there is any correlated symptomatology seen in postoperative or in further course of the disease, they are revisited back. So I think that's the take that is currently being taken on these type of hypometabolisms.
Thanks, Shwetal. Dr. Kishore Chaudhary, Dr. Sarang Rote, and Dr. Sankla are the organizers for this, and I was going to request Kishore to prakat व्हायला सांगणार होतो मी तुम्हाला, कारण I think you have quite a few questions and comments probably to make, and then I leave it to the organizers. So thank you guys for this opportunity, and I'm sure we'll meet again.
I think Suresh had to go. That's why he asked me to step in. And thank you, Shekhar. Thank you, Datta. Thank you, Milind, for being there. It's been an excellent webinar, even if we had some starting issues. And can I ask Saran to just say what?
Kishore, you had asked one question about a straight vertical incision. There are reports. The Saudi Arabian people use, there is a series that they use mini craniotomy with the vertical incision, but I would a little bit be uncomfortable with I want a medial lateral extent. I want quite a good extent from the tip of the temporal lobe till the petrous. So that gives me a wider exposure.
bit of more comfort zone. The reason I didn't pursue it, I thought it was a bit of a silly question to ask.
No, it's quite valid, quite valid.
Because for all temporal tumors, I have done away with the standard question mark flap. I usually take a preauricular straight vertical incision. And you can both temporal pole as well as quite posteriorly into the temporal lobe as well. So I thought whether you could deploy the same thing for epilepsy.
Here we have to do the ECOG, that's why I require a larger exposure, medial lateral.
I understand, yeah. So that's great, lovely. Is Saran there? Saran, you want to say a few words before we conclude?
Yeah, thank you. Good evening, everyone. I would like to thank all the eminent speakers, Dr. Muzumdar sir, Dr. Rawat madam, and Dr. Shwetal for their excellent and informative talks. Thank you, Dr. Dev Pujari sir, for moderating the session. And I would also like to thank the expert panelists, Dr. Sankhe sir, Dr. Amit, and Dr. Nilesh for the great discussion. I would like to announce that the next webinar topic will be on the spinal dystrophism. Thank you, everyone.
Thank you, everyone.
Thank you, everyone. Thank you very much. Thank you, sir. Thank you, Amit. Thank you, Shwetal and Nilesh.
Thanks all the panelists.
Thank you, sir.
Thank you. Thanks a lot.
Good night. Good night.
Good night.
Thank you, Himanshu.
Okay, sir. Good night, sir.
Good night, Himanshu. Thank you.